Madhavi, I think that we can begin when you're ready.
Okay, sounds good. Okay, so I'll get us started. So hi, everyone. My name is Mdrbd. I'm a senior public health analyst in the Division of Maternal and Child Health Workforce Development, and I'm the team lead for the Pediatric Mental Health Care Access Program. And I would like to thank you for joining us today and welcome you to the second HRSA MCHB Evaluation Capacity Building webinar of the year. So today's presentation, we actually have a really nice lineup of speakers. First, HRSA will share updates, and then we'll hear from the Alabama Pmhca, Mississippi Pmhca, Nebraska Pmhca, and Florida Mdrbd programs about patient and family level data collection. But before the webinar ends, there will be an opportunity for programs to engage in discussion around these strategies and to ask questions of our speakers. So now I'm going to turn it over to Susan to start the webinar. Thanks, everyone.
Thank you, Madhavi, and good afternoon, everyone. I'm Susan Hayashi from JBS, and I'm the project director for the HRSA MCHB evaluation contract. We're happy to have you join us today for the second evaluation capacity building webinar that will be held this project year, which ends in September. Before we get started, I'm going to provide some housekeeping details regarding webinar logistics. For today's roll call, please enter your state and your program name, that is Pmhca or Mdrbd, into the chat box. So you put your state and then there you go, New Hampshire, thank you. At the end of today's presentation, we will have a question and answer session. Please hold all questions regarding the presentations until the end, when it is time for Q&A. Please use the raise your hand feature and we will unmute you so that you can ask your question. You can also type your questions into the chat box at any time. If you're having technical difficulties in the webinar, please use the chat box for assistance. Please type your question into the chat box and push send, and we will assist you as soon as possible. Today's meeting will be recorded. Once the recording is available, a download link will be provided for all awardees. And I just want to say also is that right now this is we are conducting the evaluation capacity building technical assistance calls with a subset of awardees. For this year in our contract, we're not able to call all awardees, but it's truly one of our favorite times when we're able to interact with you and learn about your programs on a one-on-one basis. And next year, we look forward to having calls with all the awardees. So I will now turn it over to Madhavi to provide some updates from HRSA.
Thank you so much, Susan. Yes, everyone, I would like to provide a few HRSA updates. First, I wanted to start off with, and thank you for forwarding the slides. I'd like to start off with a brief update about the request for information on program components. So I know that we've shared a lot of information requests with the Pmhca and Mdrbd awardees over the past few months. And I wanted to just touch base on the request for information where we asked about HRSA funded and non-HRSA funded program components and data that you have available for those components, and how that information is stored and if it could be shared with HRSA easily. So I just wanted to just briefly go over a couple of definitions that we're working with, why this is important, and the status of responses so far. So just to quickly go over the definitions. So when we were talking about HRSA funded data, we were specifically talking about HRSA required reporting data collected only from HRSA funded program activities. Which typically for new programs, programs that funded with the HRSA funding, this is probably where you're at in terms of having HRSA funded data. You have the HRSA required reporting data only from your HRSA funded program activities. However, for programs that were already in existence prior to HRSA funding that may have expanded or built upon what was already in place, before HRSA funding, there might be a non-HRSA funded data available. So when we speak to that, we mean that these programs have HRSA required reporting data collected from HRSA funded program activities, and there might be existing data from non-PMHCA or Mdrbd funded program activities or program components. So these are the two definitions that we're operating with. So why is this important? HRSA feels that collecting and reporting on non-HRSA funded data separately from HRSA funded data provides additional context for HRSA, PMHCA, and Mdrbd programs and information regarding the true reach of your program. So I just wanted to make a note that, this is not a requirement. This is not something that HRSA, can mandate or require you to do to be able to provide this data separated if you have it available for your program component. Because you have, as I mentioned, HRSA funding as well as other funding sources to support your program. But we hope that this data, is available, that you have access to it, that you are collecting it, and that, if we were to reach out to you to ask you to report this data separately, that you would be able to do so. So we're still working through the information that you've shared with us through this information request in terms of determining next steps, but just wanted to communicate why this is important for the national program evaluation. In terms of status of responses, we've received responses from the 2018 and 2019 PMHCA awardees. We are working to receive information from the 2018 Mdrbd awardees. And as I mentioned, determination on this type of data submission is forthcoming. So we're still working through this. For the 2021 ARP PMHCA awardees, just wanted to communicate, the importance of working on this from the beginning, depending on what kind of category you're in terms of this request, being able to set up your data collection systems to collect and report this data if you're asked to do so. If we have time during the Q&A of this webinar, would love to hear from the 2018 and 2019 awardees about how you've set up your data collection systems, to be able to provide data to HRSA, regarding this request if you're asked to do so in the future. So it'd be a good time to, kind of just get some brief examples and maybe just to do some peer-to-peer exchange. Next slide. So in terms of the community linkages survey, we also asked you to provide some information, as you review the community linkages survey instrument. It's a new survey instrument that we're proposing to use in the national program evaluation. We asked you to review that instrument, and we have definitions that, or I guess a kind of examples of what we mean in each program in Mdrbd and PMHCA, what we mean by community linkages. So in terms of the Mdrbd program, you can see the definition here. Recipients are expected to establish linkages with and among community-based resources, including mental health resources, primary care resources, and support groups, and to develop or enhance partnerships to expand treatment and recovery support service options, and to establish those partnerships to coordinate services and activities to achieve program goals as it relates to, being able to connect providers and patients to treatment and support, recovery support service options. So as we were, as JBS was considering this language in the NOFO for Mdrbd, as well as guidance that's been provided to awardees, a definition was created for the national program evaluation that refers to these partnerships as community linkages. These community linkages can include, but are not limited to community resources, programs, or services like counseling, childcare, and housing support. So this definition, or I guess, this language around community linkages carries over to PMHCA as well. So in the PMHCA NOFOs, we ask, our recipients are encouraged to develop partnerships statewide and or regionally with a broad range of community-based behavioral health clinicians to provide that specialty care to increase access to behavioral health care, either through telehealth or in person, and also to be able to provide referral and care coordination support for children, adolescents, and families. So, and as the PMHC awardees know, that a lot of this work is carried out through the development of the resource and referral database, also through participation in your advisory committee. So these, community linkages really help in terms of being able to provide those resource and referral points to providers and families as they relate to, increasing access to behavioral health care, to child care, housing, food supports, a whole range of community resources. So I just wanted to say that, we understand that there are nuances in terms of, how programs are thinking about community linkages. We appreciate all of the feedback that we've received from you thus far on community linkages and how you are interpreting the community linkages survey. We are taking that feedback into consideration and thinking about if any adjustments need to be made to the survey. So, just stay tuned for additional, guidance from us and, responses to your feedback and whether there might be some adjustments made to the survey. But, just wanted to just share that information really quickly, that it is important for us to really be able to capture referrals and outcomes from referrals in the national program evaluation. That's an area that wasn't as well defined in the original evaluation design. So, we really want to make sure that the community linkages survey, is relevant to the data that you're collecting, that you're able to provide it to us through that survey, and that really have an impact in terms of enhancing the national program evaluation for both programs. So next slide. So I just wanted to close out HRSA updates by just reminding, especially the PMHC awardees, and I believe this also applies to the Mdrbd awardees, that annual non-competing continuation progress report instructions will upload in the electronic handbook in mid-May. And for the 2018 and the 2021 awardees, the 2019 PMHC awardees already submitted their progress report for the year, and we're in the process of reviewing your reports. So for the 2018 and 2021 awardees across both programs, the instructions will upload in mid-May and progress reports will be due in mid-June. Also just wanted to say, take a look at the PMHCA webpage, and here's the link. We recently uploaded several PMHCA program videos that highlight the impact your programs are having on providers and children, adolescents, and families that those providers care and support. So, some really great and powerful videos that are now available on our site that demonstrate your great work. And also just wanted to just remind folks that Kelly Hughes sent out an email on the PMHCA listserv on April the 12th, asking for PMHC awardees to consider submitting stories that highlight how your program is commemorating and observing National Children's Mental Health Awareness Day, which is May 5th. The week is May 1st through 7th, and there's also Mental Health Awareness Month, which runs the entire month of May. So if you have a story, something that really highlights how you're commemorating and observing these important events, please share your submissions by close of business May 4th with Caitlin Bagley, and her email address is here. And if you need more information about the request, please review Kelly's email from April the 12th for more details. But we'd love to receive your stories and be able to highlight them. And then now I think I'm going to turn it back over to the JBS team to introduce our awardee presenters. So thanks, everyone.
Thank you so much, Madhavi. I just want to also, a couple folks have just joined, and the recording will be available because Madhavi just gave a number of HRSA specific updates, so those may be relevant to your programs if you just joined the presentation. So next slide, please. And now we're moving into our, I guess, featured event. Here is the number of awardee presentations. And I'd like to start with Alabama Pmhca. So next slide, please. And I'd like to introduce our speaker. Ann Brizendine is an assistant professor at the UAB School of Public Health in the Department of Health Policy and Organization. As the science director for the school's Applied Evaluation and Assessment Collaborative, Dr. Bernstein leads a portfolio of public health practice projects focusing on improving outcomes around maternal and child health and mental health in the Deep South. With a high level of support from Senior Program Manager Lizzie Taylor, Dr. Brizendine leads the Mixed Methods Evaluation for the Alabama Pmhca program known as PATHS. So Dr. Brizendine.
Hey everyone. Again, Ann Brizendine from UAB, working with Alabama, our PATHS project. Lizzie Taylor is also on the call today. She is really one of the most indispensable parts of this project. So I want to acknowledge her and the incredible work that she's done to support this evaluation. And Susan Griffin, our intrepid leader, is also on the call and want to acknowledge her as well. Just going to talk briefly about our parent and family and caregiver engagement portions that we have done about our evaluation. So if you'll skip to the next slide. It's part of sort of our broader mixed methods evaluation strategy for PATHS. And you can sort of see here, we try to take a multi-pronged approach to talk with the enrolled practices. And we're accessing them through surveys. We're using an ECHO model for training and capacity building. So we get some really great information from post-series surveys there. And then we also do key informant interviews with them. We also engage our internal team through semi-structured interviews as well to really be able to tell the story of how PATHS rolled out, what they're hearing from providers, what they're hearing from families and clients of the program, and then also supporting with HRSA data reporting, though I will say that the internal PATHS team is doing most of that themselves. They've really become sort of stellar when it comes to data reporting. And then this piece, so the family and child outcomes portion, we had hoped to sort of be able to access them through surveys. That's still on the table, but really we've been leaning a lot on key informant interviews and other strategies for around other outcomes data. So if we go to the next one. So again, impact on families in Alabama. And Alabama, as many of the other rural states who are involved in Pmhca programs know, this kind of work, this access building work for incredibly rural states is truly key. But the challenge is in rural states, it's also very difficult to access the people to understand how things are going. So we had to overcome some hurdles and we learned and sort of pivoted during the process about sort of who we were going to talk to. So I'll be able to tell a little bit of that story here. So next slide, please. So as you sort of saw in that multi-pronged approach evaluation strategy that we have, we really started talking to our providers because they were the easiest ones that we could talk to. And so our initial interviews were really around how are things going, but then also getting a sense from them of what they were hearing from their patients. So what were their perceptions of what some of the outcomes and benefits were? And we'll see some of those on the next slide. So what we were hearing from providers was that they felt as though families were feeling comforted by the collaboration with the PATHS team and with the relationship with Children's of Alabama, so the Children's Hospital where PATHS sits. They really appreciated that their provider was taking additional steps to support the family and child, and that the process felt really collaborative. So our providers were hearing this from families. They were also their perception was that families were gaining access to services that had been previously unavailable, They were seeing some increased knowledge of available resources in the community, and they were also seeing improved quality of life from the family. And this is great to hear from the providers. We want them to be receiving this kind of feedback. But we also sort of heard from them, we're like, well, this is what they're telling us. Who knows if they're just telling us, telling this to us to be nice to us, or what? We really want to understand. And so with that, we moved forward, and we'll see with the next slide. Semi-structured interviews with PATH's families. We had initially, wanted to capture folks. PATH's has a 3-tiered strategy. We've got the training, so the ECHO model, provider-to-provider consultation, and then direct telehealth provision. And so we sort of wanted to see what those 2 tiers of that provider-to-provider consultation, so families that only received that service, as well as those who received both consultation and telehealth. And we'll talk in a couple slides about where that didn't exactly happen. So on our next slide, we had heard this, and we sort of wanted to test this, that PATHs opened up the opportunity for families to take advantage of things that were not available to them. Did this bear out to be true? And so actually, if you'll go ahead 2 slides on this one. Awesome. We conducted these interviews over about 2 months, 6 weeks last year, right as we were getting back into our offices at UAB, and then right as really families were getting to the end of a very long school year, entering the summer. So really trying to time that creatively and carefully. And our goal really was to understand the caregiver experience related to the services provided by the program. We ended up doing 8 interviews across 8 different rural counties, and we were really intentional about bringing in different types of caregivers. So understanding that we always expect that mom will be the one who's providing a lot of this information, but we were also able to interview a father, a grandmother, other types of caregivers. So if you'll go back a slide, if we can, yes. So you can sort of see our breakdown of participants here. We had some variation in the relationship to child. We had variation in the counties. So we were really tried to be as thoughtful as we could about who we accessed from northern, middle, and southern Alabama. We also tried to go get a broad range of age of child who were receiving services, and then also gender of the child or children. You'll also see that we had some twins in here who were accessing services. So again, 2 ahead, and we're back on schedule. So outcomes and perceptions of consultation and telehealth services. For the consultation, that provider to provider, again, families were happy with the consultation services because they have confidence in the providers at Children's. Children's of Alabama is one of, I believe, 2 pediatric hospitals in the state, the only one sort of that serves this middle and northern portion of the state. It has an incredible reputation. You've got folks coming from other states on occasion to access some of these services. But for someone who may have to drive 4 hours from rural Alabama, it sounds great, but it's really hard to access. So to know that they're benefiting from this really gave them not only confidence in the care that they were receiving, but also additional confidence in their providers, because they were somewhat impressed. They were pleased that their providers were able to access this and did it on their behalf. They were supportive and appreciative of the access without having to drive. We heard that a lot. We know that transportation is a major barrier in our state, as it is in many of other sort of predominantly rural, deep South states in particular. And so to be able to do that without having to take off a full day, 2 days of work, without really having to worry about childcare for siblings, those kinds of things, it was wildly helpful for these families. And again, they were trusting of the pediatrician and appreciated that their primary care provider understood their own limits and had an outlet for support. So it gave them faith and confidence in the care that they were receiving, because it wasn't someone sort of fumbling blindly in the dark. Looking at telehealth services, so those families that received the direct telehealth visits, they trusted in their pediatrician guidance and what they recommended for the support of their child. So they appreciated that their pediatrician said, we've exhausted some of these other options, and now we want you to try this. So they had followed along with the process and felt confident in their ability to continue. Again, they trusted in Children's Alabama's standard of care, and they were incredibly thankful and grateful for access to these high quality services. They were able to build comfort and trust with the PATH's providers, which supported that rapport and connection between the provider, both the PATH's provider at Children's, their primary care provider, as well as the caregiver and child. It really became a team approach. And then also improved behavioral health systems and improved behavioral health outcomes following the telehealth services. And finally, improved communication with their children about their thoughts and feelings. So not only was it supporting this broader system of care, but it was really supporting that child and caregiver interaction and relationship. Next slide, please. So a note about wording. We talk about consultation and telehealth when we talk about PATHs. Families, when we said consultation, it required on Lizzie's part, as she was doing these interviews, a lot of reframing to sort of talk about what consultation meant. And so when we sort of said, were you aware that your pediatrician talked to some other providers about care for your child? That's when things started to click in. Now, not every caregiver knew that before they received telehealth services, their pediatrician was accessing PATH's providers through consultation. But I can say that no one really understood the wording around consultation. And that sort of really inspired some great internal conversations with the team about, how important is it for these patients and these kiddos who are receiving these services and their families to sort of understand the structure of PATHs, how important is them for them to know the name PATHs. And I don't know if we sort of landed anywhere on that, but those conversations were really great as we're building the program and looking towards sustainability. Next slide. The best outcome from these conversations were to get some of these incredible quotations. And this is great when, again, we're looking towards sustainability and talking with other partners, but also to reflect to the pediatricians who are enrolled in the program and the internal PATHs team to support morale, to really reflect back the impact that they are having on these families. And from one caregiver we heard, as far as improved, she's not as anxious as she was. She was having a lot of crying episodes and was very depressed. She was suicidal and homicidal, and now she's totally different. At one point, she wanted to give up, and now she's taking college. She's engaging in extracurriculars. So that right there tells a story so much better than anything that we could ever drum up ourselves. Next slide. Again, we were also able to sort of access the perceived strengths of the program. Again, consistent availability that's producing lasting change. Flexibility, ease, convenience, good connection and communication with their pediatrician as well as the providers, and access to high quality services across Alabama that they previously couldn't access. We did also ask about challenges, and the main thing that came up was, again, from the providers who are enrolled, but also from families, was we don't want to lose access. So can we sort of keep this tied up for ourselves? And so really being mindful about moving forward. And then two last little quotations here on the next slide. At first, I was skeptical about it because I felt like you can read a person better in a face-to-face visit versus talking to someone through a screen, but I was willing to try it and have not been disappointed. So as you can see here, there was some distrust around the telehealth model, but really the rapport was able to be built. And then this last quotation as we wrap up. I didn't know what to do or which way to go, but after being introduced to the program, it's a complete turnaround. For the first time in a long time, I feel she has a great opportunity for the future. And with that, I feel like everyone's used that quotation and someone's going to burst into tears, and I will try not to be that person today. So we'll take questions, I guess, later, but thank you for giving us the opportunity to sort of share what we were able to find out.
No, thank you so much. I have to say I was starting to get choked up seeing those. So I mean, that's really what these programs are about and making that difference. And so thank you for everything that you shared. I, did make a note for a question if there's time about some of the patient outcomes and how you measured those. So if we have time for that would be great at the end. But at this point now, if we can go to the next slide, I'd like to introduce the team from Mississippi that will be presenting. And Dr. Sarver is a licensed clinical psychologist and the clinical director for the Child Access to Mental Health and Psychiatry program known as CHAMP, operated out of the University of Mississippi Medical Center. Dr. Sarver completed his PhD in clinical psychology in 2013 and a postdoctoral fellowship in 2014 before joining UMMC. He specializes in child neurodevelopment and behavioral disorders, parenting interventions, and early systems of care. In addition, Dr. Hogue has been the executive director of Families as Allies since 2011. She is particularly interested in policy and system change that supports and engages as many families and recipients of services as possible. She has a 20-year-old son. Together, they have traversed different systems and challenges and learned a lot about self-advocacy, their love and trust for each other along the way. Before she was a mom, Dr. Hogue became a licensed psychologist and will forever be grateful to the families who patiently taught her about family-driven practice as she did that work. And we've got contact information if needed available, but I'd like to turn it over to Dr. Sarver and Dr. Hogue. So thank you.
Thanks, Susan, for that. Good afternoon, everyone. Very nice to see you guys on this presentation today. I'm just going to very quickly just point before handing it over to my colleague, Dr. Hogue. Just wanted to say that CHAMP and Families as Allies, we really are, from the very beginning, from our application, have strived to develop a partnership that that really emphasizes family-driven practices. Dr. Hogue will speak to, and so just with that, we as CHAMP team will do a lot of the more consultation-related stuff, but in partnership with a lot of the other activities that we in support that we receive from Families as Allies. They really truly are our key partners in this. And so just to hype her up on and what they do, I'll kick it over to Dr. Hogue, but I'm very glad to do this with you today, Joy.
I feel the same way, Dustin. This is CHAMP is one of my very favorite things to talk about just because of the partnership we have. And we can go to the next slide. So Families as Allies, we're the only statewide organization in Mississippi run by and for families of children with behavioral health challenges. So all of our staff who work directly with families and also most of our board members are raising or have raised a child with a behavioral health challenge. And we support each other as families, and then we work together to make things better for our children. And when the CHAMP project was being conceived and they were writing the application, we knew that this was something that would make things better for our children because we trust our primary care providers and we know that that's where they can get some of the best care, and knowing that they could get mental health care where they already are meant the world to us. And you can see our vision and our mission. And our mission is that families are partners in their children's care. And I'm going to talk a little bit more about that in just a minute. And we can go to the next slide. These are our core beliefs about families. Sometimes people think we go around trying to make families do things, but we don't. We go around, we believe that families are their child's strongest advocate and that they already know their child better than anyone. And so we want to support them in that, in advocating with them for whatever they want for their children. And we realize that sometimes there's been a lot of barriers and issues that have kind of worn families down. So we want to address those. So our third belief is that systems should follow laws and policies about families and children's rights. And although this is a little bit of an aside from this particular presentation, it has been wonderful to see the ways we've been able to work on that with CHAMP with some of the education issues that families face. And we support families, community, and positive change. And through CHAMP, we've been able to support all of those even more strongly than we were. We can go to the next slide. So this is the definition of family-driven practice, and this is from the National Federation of Families, and we are, and I meant to mention this a minute ago, we're the state chapter of the National Federation of Families. So if any of you are listening to this and wondering, is there a group like this in my state? There probably is, and you can go to the National Federation of Families website and find that. And we also, and I don't think you know this, Dustin, we were just awarded through HRSA, the Family to Family Health Information Center grant for our state too. So Family to Family Health Information Centers can be a tremendous place for these partnerships too. But this is from the National Federation of Families, and this is also several different national groups use this definition, that family-driven means families have a primary decision-making role in the care of their own children. And then this next part is what I really want to emphasize, as well as the policies and procedures governing care for all children in their community, state, tribe, territory, and nation. And you can see that's about designing, implementing, evaluating programs, monitoring outcomes, partnering and funding decisions. And we really have been able to do that with CHAMP, and they've had us at the table from the very beginning. And then there are some specific projects we've worked on through CHAMP in partnership with CHAMP, looking at how to be as family-driven as possible. So we can go to the next slide. And this is one of those that we did with CHAMP, is together we created a survey for families about their experiences with their primary care providers. And we put the survey out through our newsletter on Facebook, and it was kind of a little bit into the pandemic. You can see the information there. And we didn't get as many responses on this survey as we typically do, although we got a pretty representative group of 57 families or 57 parents who participated. We do think there was maybe a touch of COVID online burnout with trying to do things online with families, but we got a representative sample that pretty much reflected the demographics of Mississippi, and you can see those there. And we got, as far as the respondents, a wide range of types of caregivers, and the demographics are pretty reflective of Mississippi. So I will turn this over. We can go to the next slide, and I will turn it over back to you, Dustin, to talk about the results.
Thanks, Joy. Yes, so we had a very brief survey. These are just to put everything out there for people to digest here. So I'll just kind of touch on the overall themes that we got from this. So across the sample, when we were asking the first question about more identification of the issues, so families being able to think that their doctor is able to tell if their child is having emotional or behavioral difficulties. You know, by and large, you see somewhat that most were agreeing with that. Although across the board, it is important. I think that this was the question that had the least of the strongly agree. So I think families are saying that yes, they think their doctors can help them identify needs, but maybe not very as strong. So I think it speaks to some of the Pmhca work in terms of working with identification of mental health concerns in the primary care home. The second element, looking at, I feel like I can go to my child's doctor to get help. We're very glad to see that most families do believe that they can get help in their doctor. That's especially related to mental health concerns, so that we know that this landscape across the last decade or so has really shifted to having mental health in the primary care home. And so it's nice to see that that's reflected here in our state at this point. One of the things that I think is really important to me is to realize, and I don't know if this is maybe somewhat of a respondent bias, that there was certainly more people saying that they felt like there were places that they can go and receive help to, or that their provider can provide referral to in their area. So we definitely, one of the core activities of all of our programs is to connect families to services through providers. So I feel like we're able to hit on that. The next question is, to me, maybe the one that I find most drawn to, in the sense that families, it illustrates the overwhelming attitude, as Joy said, that families desire family-driven practice. They desire to be able to have a contact that they can go to and be where they're trusted. And so with 95% of the families agreeing or strongly agreeing that it's important that their doctor be able to help problems. So often, especially here at a place like in Mississippi, and I no doubt many of the other states, things are segmented and siloed, and it's you have a long winding wait list to get to the services that are needed. I think that it's important for us to use this survey to really communicate the message to providers that families want to be able to have these things taken care of when they go to a visit, and that PMHCAs that we can provide those that support to providers, so that can ultimately families can get the help they need in the place that they already go. And finally, kind of looking at the satisfaction of the families feel like they are getting from their doctor in terms of addressing social, emotional, and mental health challenges, pretty sped over the board. It was interesting to me that about a third of families are saying that they are not satisfied in that. And I feel like, again, we're to use these numbers to be able to describe to our physicians that we're trying to recruit, to the ones that are already engaged in us, that it's important that to parents that they be satisfied in that care. And I think that it also speaks as to a potential messaging tool in order based on value-based payments. The healthcare landscape is certainly shifting, or has shifted in many respects, to including patient satisfaction and value-based elements. I feel like if those payment models move to that, it's going to be important for us to use this type of information to help impress upon providers the need to improve patient satisfaction. Next slide. So in addition to some of the quantitative comments, we also have a sampling of qualitative comments, and I'll just kind of highlight here. I won't read them all because I know everybody here can read, but I'll just point that they each illustrate an element of the survey results, in the sense that parents can either feel frustrated that they're not getting connected to services, or that it takes so long for them to be their problems to be identified, or their child's problems to be identified and connected to services. Whereas in contrast, families who felt like their physician was in contact with them, that they could communicate to them on a very close level, they had lots of satisfaction with that. And that, to me or to us, that really illustrates the idea that those providers are actually providing family-driven practices within the clinical work that they do. And so, it's also that last point, I think, does just illustrate that these connections don't have to be, they can spread out from the medical home. This example of a parent who was feeling blessed that their social worker in the school was able to connect and coordinate with the primary care doc, just shows that that still is a family-driven practice. And so we do these things with. I feel like this next slide, please. Across the board here, really emphasizes again that families want to have their doctor notice things, and we all know that, but I think it's just the results underscore that. And it's important for us to teach these providers to have to use evidence-based screening tools, and then ultimately to be able to connect with specialists like us to be able to again provide care in the place that's needed. So I would love maybe in a future time to be able to talk with some of the things that Joy and Families as Allies are doing with us in terms of now actually being on some of the consultations that we provide relevant to advocacy or patients' rights. So we're just joyful to be able to be involved with them in this, and to the extent that there is a Federation of Families organization in your state, I highly encourage you to other programs to work with them, because they've been Families as Allies has been wonderful to work with.
Thank you so much, Dr. Sarver and Dr. Hogue. Really appreciate your comments and what you've shared. If I recall correctly, didn't Mississippi have a video that introduced the program? And just for any new awardees, that I think that you all found that very beneficial, and that that there was an awareness, and that the consultation line, that there were accessible staff to support that. And so just so that everybody is aware of that, and appreciate the comments today and the insights that you shared. Now we're going to move on to Nebraska Pmhca, and we have Jessica Earn with us, and she received her Bachelor of Science from Creighton University and obtained her MPH degree in the Maternal and Child Health concentration from the University of Nebraska School of Public Health in 2020. In 2021, Jessica began her role at the Center for Reducing Health Disparities as the Community Research Data Coordinator. At the center, she focuses on maternal, adolescent, and child healthcare access, and racial and ethnic health disparities. Welcome, Jessica, and I'll turn it over to you now.
Hi, everyone. Sorry, I'm losing my voice a little bit. My daughter gave me a little bit of a cold, so I'm going to try to project for you. So like the introduction, my name is Jessica, and I will be representing on behalf of the Nebraska Partnership for Mental Health Care Access in Pediatrics, or NEPMAP. And we're a collaborative and cross-sector team, which includes a clinical demonstration team, some advisory committees, parent groups, and clinical partners, as well as the evaluation team. I am part of the evaluation component, which is housed at the Center for Reducing Health Disparities at UNMC's College of Public Health. And today I'm going to present on the results of one of our current projects, which is the statewide assessment of mental health needs and services among children in Nebraska. And this project allowed us to utilize our parent advisory committees and our clinical partnerships to gain a picture of kind of what's going on with our kids in Nebraska. So next slide, please. So we had several purposes for this portion of the project. I'm not going to list all of them just for the sake of time, but we did want to look specifically to the extent in which parents agree that they have access to needed family supports. And we also wanted to look at the impact of COVID on the emotional and mental well-being of families of children and the programs that are available to help children and their families to cope with the COVID pandemic. And we also wanted to look at some of the impact of COVID-19 on clinical practices of participating pediatricians and of effective coping strategies, such as the use of telehealth services. So next slide, please. Okay, so for this project, we kind of divided it into two portions and then combined it. So the first portion is going to be a survey on the family perspective of what's going on with their children in Nebraska. And then the second portion is going to be the perspective of providers in Nebraska that are providing mental health services to children. Next slide, please. Okay, so in the family perspective survey, we adopted an online survey that we just kind of sent out through snowball sampling to kind of gain the perspective of what's going on with parents and caregivers of children with mental and behavioral health issues and just children overall in Nebraska. So in order to be eligible to participate, they had to be at least 19 years of age, currently reside in Nebraska, and then live with a child or children under the age of 18 years. And we collected data from 373 parents or caregivers between June and August of 2021. Next slide, please. Okay, and then for the provider interviews, we did semi-structured interviews with providers that were working with pediatric patients in Nebraska and that were providing mental or behavioral health services. And we collected data from 18 key informants between June and August of 2021. So next slide, please. Okay, so for the results, I'm just going to kind of give a brief highlight. We do have published reports on both of this that have extensive results, but I just want to give what we thought were kind of some of the major results. So next slide. So for our parent perspective sample, we identified that most parent respondents were between the ages of 25 and 44. They were female, non-Hispanic, Latino, and Caucasian white. They tended to be married, have 2 or more incomes contributing to the household, and held at least a bachelor's degree. we found that 66.2% were in single child households, with more urban households having single children than rural households. And we were able to gather about 50-50 from urban and rural areas. Next slide, please. Okay, so the main 4 areas that we wanted to talk about today is child happiness, mental or behavioral health issues, service utilization, and then care utilization during the pandemic. Next slide, please. So first, we're going to discuss child happiness, and you can go on to the next slide. So using a scale of 1 to 10, we asked parents to identify how happy their children were or their child was right before the pandemic, and then currently right when we gave that survey, which is after one of the longest school years known to the history of man. And so that was right during that summertime before we knew if we were going back to school or not here in Nebraska. So next slide. And then as you can see, the average happiness rating that we got from parents or caregivers was an 8.1 out of 10 before COVID, which then dropped down to 6.8 out of 10 after or during the COVID pandemic. And then if you want to go on to the next slide. So the next key topic that we are going to talk about is mental or behavioral health issues that were present at the time of the survey. So if you want to go on to the next slide. So we asked this question just during the last 30 days, which when we gave the survey out, it was in that summer time. So children had not returned to school yet. We asked if any of their children showed symptoms or signs of mental or behavioral health issues. And then we gave a couple of examples such as depression, anxiety. There's a list right there. But if you want to go on to the next slide. So we saw overall in the statewide sample that 37% had said that there was no change in the mental or behavioral health of their children in the last 30 days. But of those who did express some concern, anxiety, depression, and restlessness were the top 3 reported issues that emerged. Next slide, please. And then if we break this down further to kind of look at our rural sample versus our urban sample, we notice that there are more rural respondents who had said that there was no change in their child's behavior, mental or behavioral health in the last 30 days. But among those who reported it, depression, anxiety, and restlessness remained the top 3 issues. But then we look at that next issue in rural areas, there were more issues with aggression. And then in urban areas, there were more issues with ADHD. Next slide, please. And then when we asked our providers the same question, they did identify anxiety, depression, and ADHD as the primary mental or behavioral health concerns expressed in their population. And then some other issues that came up just depending on age and population included ODD, stress-related disorders, behavioral disruptions, post-traumatic stress disorder, substance use, autism, learning disorders, and eating disorders. So next slide, please. So then we wanted to also know specifically if there was anything with COVID that they were noticing, and our providers in their interviews did acknowledge that there was an increase of pediatric patients coming in with new issues, and then also an increase in the severity of pediatric patients who were already identified with some sort of mental or behavioral health issues. And the ones that they identified specifically with COVID-19 concerns included anxiety, depression, and family stress. And then some of the other issues that came up included anxiety resuming to in-person school, self-harm tendencies, family stress, fear of going back to virtual school, suicidal ideation, and then just the lack of available mental health resources. Next slide, please. And then we wanted to look and see what was going on with service utilization in the state at the time in that summer between June and August of 2021. So next slide. So asking who was currently utilizing any supports or services for their children, statewide, there was 54.3% of the respondents said that they were versus 48.3% in the rural sample. Next slide. And then looking to see specifically what services were being utilized, the top 3 statewide would have been primary medical care, special education, so either an IEP or an IFSP, followed by behavioral mental health care. But if we transition to look at the rural sample, we do notice that more of the rural respondents were relying on an individualized healthcare plan than any of the state respondents. Next slide, please. And then we also wanted to know if they did receive service, how easy was it to access those services? So statewide, 36.8% of the sample had said that they had no problem or were able to do it on their own. Only 26.5% of our rural sample was able to do that. And then both 2.3% in the rural and the overall sample had said that they had not been able to access services at all. Next slide, please. And then looking more specifically at what barriers existed, we identified at the state level that language or interpreters were the largest barrier, followed by distance and travel and financial. But if we looked at the rural sample, we figured out that distance and travel, financial, and then how many appropriate providers available in the area were the three major barriers to accessing services. Next slide, please. So when we asked further from our providers what barriers they saw from their perspective, so barriers external to the clinical setting, they identified transportation, insurance instability, lack of qualified providers, stigma towards mental health, and lack of insurance coverage that prevented families from coming in to seek services in the first place. So next slide. And then barriers within the clinical setting. So some of the barriers that they found would have been language barriers or lack of interpretation services. Providers offered limited hours of availability. They perceived patients need more time than allowed in the schedule. And then providers did not have resources that matched the patient's health literacy level. So next slide. So now looking at care utilization during the pandemic, we're going to kind of go through these pretty quickly. If I can go to the next slide. So 38.6% of our rural sample had delayed care in comparison to 46.1% of the statewide. We can go to the next slide. 54.4% of the entire state service had used mental health utilization during COVID. 52.8% of the rural sample had used mental health services. Next slide. And then 49.3% of the statewide sample had used some sort of telehealth. 43.8% of the rural sample had used telehealth services. Next slide, please. And then when we asked our providers issues with telehealth services, they brought up insurance reimbursement, lack of research into the effectiveness of treatments, and then internet access for patients as the major issues with telehealth services and providing those services. So next slide. And then as a team, we came up with a couple of next steps to kind of focus on as far as evaluation and research. And so one of the major things is that we do need to kind of hash out the availability of telehealth as a family-friendly solution to access barriers. And we need to recognize that mental and behavioral health issues are not limited to the identified population of children and youth with special healthcare needs. And then we really do need to continue to monitor children for developing mental and behavioral health issues as the COVID pandemic continues. And we need to do some linkages with primary care providers to child serving community referral systems. So next slide. And then in conclusion from this and moving forward, what we found is that overall children's happiness and emotional well-being has decreased throughout the pandemic. 25% of families expressed difficulty seeking services, and about 25% of families reported children with learning disabilities and or special needs, but there was over 50% that reported support service utilizations. So we need to take a look into that and to see if the need among children not previously identified as having issues is higher or what's going on with that. So that is everything that I have.
Okay. Well, thank you so much. It was a great presentation. I can already see a couple of questions that come to mind for me that maybe if time permits, in terms of if you made any shifts in your program implementation or if you're looking at any of potential shifts focusing on any of the rural populations, and also understanding a little bit more about the rural versus statewide, if the statewide eliminates the rural population or not. And so that just would be interesting if time permits on that. So we are just going to take a moment and switch a slide deck. We have hot off the presses some slides updated slides from Florida Mdrbd, and want to get those loaded. And we are just going through to set that up. And then I will introduce Dr. Megan Deason-Watson, and she serves as the Technical Assistant Specialist for Florida's Behavioral Health Impact Project. Dr. Deason-Watson's role is specifically focused on translational care within the the translational care within the project, which includes disseminating research to enrolled providers and documenting data points related to program implementation. Dr. Deason-Watson has a special focus on documenting inequities in care and strategies for enhancing care equity, particularly in relation to care accessibility. So Dr. Deason-Watson, I'll turn it over to you now. Thank you.
Thank you, Susan, for that introduction. And thank you for working with me with my complicated last name. It gives everybody trouble. My name is Megan Deason-Watson, and I am the Technical Assistant Specialist from Florida's Behavioral Health Impact Program. And I am so thrilled to be here representing the obstetrics arm of the work that is going on through HRSA's programs. Next slide, please. So Florida BH Impacts Program is an initiative that is collaborative with Florida Department of Health, Florida State University's College of Medicine, and the Florida Maternal Mental Health Collaborative. And the goal of this project is to provide direct support to providers, both in maternal and child health, by building capacity for healthcare providers to address critical behavioral health issues with their patients. Today, I'm going to be talking to you about some programming that we're doing with obstetrics patients on behalf of their pregnant and postpartum, or obstetrics providers on behalf of their perinatal and postpartum patients. Next slide, please. So this work that we do wouldn't be possible without all of our wonderful partners. We've found that the partnerships that we've made across the state have been absolutely critical to the success of our programming to date. Some of those partners include the University of Florida, the Florida Association of Healthy Start Coalitions, the Community Behavioral Health Centers, Department of Children and Families, ACOG District 12, and of course, Lifeline for Moms, whom we are modeled after. Next slide, please. We also have a fabulous support team and state collaborators that include Dr. Adam Baptiste and Melissa Newsom, and our state collaborators, Shay Chapman, Lauren DiPaola, and Don Clark from Florida Healthy Start. Next slide. But of course, this work wouldn't be possible without our amazing care team, Dr. Heather Flynn, our program director, Dr. Kay Russos-Ross, who's our psychiatrist consultant on the program, and Dr. Amandla Shabaka Haynes, who's our resource and referral specialist. And I'll tell you more about the roles that they play in a moment, but they are the crux of this work. They're rock stars, and we appreciate so much all of the hard work that they do for this program. Next slide, please. So Florida, as many of you may know, is a very large and diverse state. It's one of the most diverse states in the country. And annually, it has a little over 200,000 births. So our HRSA program was initially funded to cover 3 primary regions within the state. And those were Leon County and its surrounding rural areas, Alachua County and its surrounding rural areas, and Duval County and its surrounding rural areas. And those are highlighted in purple, fuchsia, and green on our map. But as our program expanded, or as our impact extended, we were recruited by providers across the state. So our reach is currently expanding, and you can see now we have partnerships with West Florida Healthcare, Orlando Health, Sunshine Health, St. Mary's Medical Center in West Palm Beach, and then Mount Sinai Medical Center as well. So although we're not currently represented in all of our counties, we have been steadily growing over the last 4 years. Next slide, please. Our program is made up of several core components, which includes screening for all pregnant and postpartum women for behavioral health conditions using valid screening tools. But as we all know, screening without any other supports doesn't necessarily translate to good outcomes. So our program has introduced training and supports for obstetrical clinicians, access to psychiatric consultation, where obstetrics providers can call Dr. Kay Roussos-Ross, our psychiatrist consultant, and ask questions about dosage, recommendations for best practices for psychiatric treatment for their pregnant patients. And they can also contact Dr. Mdrbd Haynes regarding referral resources for their patients. So any referrals to behavioral health counselors or any psychosocial supports, Dr. Shabaka Haynes is there to provide those resources to them. And what I want to point out for the resource database is that this is a statewide database that includes all licensed mental health providers across the state. So this really sets us apart in terms of making sure that we have the identified resources that we can share with our patients when they need them. We also provide training for community behavioral health clinicians. So not only do we provide the support to refer, but once patients are referred to behavioral health clinicians, they're receiving referrals to providers who have the capacity to be trained in our programs. And then lastly, we have an arm which includes community education and outreach for perinatal behavioral health. Next slide, please. Okay, this is just a bit of an additional review of the main components of our program. It also shares that some of the important elements include tracking and reporting of our information and measures. And this is what I plan to talk with you about today. So next slide, please. Okay, just as a refresher, our project, this is kind of our main workflow. It trains and supports frontline providers, and then the frontline providers can contact and consult with our program. Once they've contacted and consulted, it increases their capacity to diagnose, treat, and manage perinatal behavioral health disorders. And in talking with our team, we're in the process of updating this flow chart a little bit, because what we've realized is that our diagram right now is unidirectional. And the truth is that this is kind of a cyclical process, and bidirectional feedback is a critical component of that. So we will be updating this more in the weeks and months to follow. Next slide, please. So to date, we've had 179 provider to perinatal psychiatrist teleconsultations. We have over 240 providers and professionals enrolled, and we've received 42 resource requests and provided an additional 28 training and educational presentations online and in person. And what I want to add to this is that we also have outreach through monthly newsletters that include a reach of over 1,300 providers across the state. And our behavioral health trainings that we're engaging in are also a very popular resource that we will be tracking more information in the year to come. Next slide, please. So across all of our program efforts, we aim to integrate health equity into our project outreach and engagement. And in 2020, we identified a strategic plan for how we would incorporate equity across our program efforts. What we did was decided to divide those actions into core value actions, which are internal processes where our team addresses our own implicit biases, works as a team to identify power structures and maintains a culturally sensitive and humble approach to engaging with perinatal care providers and the patients that we serve. And what I want to add here is that we meet monthly to discuss these issues and identify ways that we can collaborate with the providers and patients to enhance care. And that kind of follows into this practical action component where we include accurate and up-to-date information on health disparities. We include those in things like our newsletters, websites, social media platforms, and trainings. And then we also offer increasingly specific details in our resource and referral database so that we can match patients with providers that have the characteristics that they are looking for in a behavioral health provider. So that may be gender concordance, racial or ethnic concordance. That may be a specific type of provider that they're looking for. So we have all of those details that we're continuing to embed within our resource database. Next slide, please. Because of our mission to integrate health equity into all that we do, we've developed a qualitative study with 2 primary arms to identify barriers and facilitators to care. And in particular, we've been looking at barriers and facilitators to postpartum care because we see a drastic and dangerous shift in the numbers of women and numbers of perinatal individuals that engage in prenatal care. And then once baby's born, far fewer women engage in postpartum care. And that disparity is particularly stark for persons from underserved communities. So these qualitative interviews that we've been engaging in are one of the primary strategies that we've been using to sustain momentum and buy-in from practices. We started with a series of interviews that are ongoing with providers. And so we currently have an N of 8. 2 of those are OBGYNs and the remaining are nurse midwives and nurse practitioners. And those focus on clinical practices in place in their clinics to mitigate perinatal health disparities. This sample of providers is a convenient sample that we collected from enrolled and heavy utilizer practices. So those are providers who have been calling, using our line, attending our trainings, and that we have a pre-established relationship with. And then in response to what we've heard from providers, we initiated a series of interviews with patients. And this is in a very early stage, so I'm excited to get to share with you how we navigate this process. Many of the presentations you've heard today have kind of been on the other end, where much of their patient-facing interviews and data are farther along. So I'm excited to share with you kind of what we've been learning as we've initiated this patient-facing component of our research. Next slide, please. Okay, so what I think is important to highlight in this qualitative study is the barriers and facilitators to recruitment. This has been a key component of what we've been navigating as we've initiated both arms of the studies. So as far as barriers with the providers, they're busy providers. There are numerous and ongoing measures that the providers are being requested to complete. And with the time involved with those measures, it can be kind of hard to ask providers to do one more thing, especially during COVID, where we've seen a lot of burnout with providers. And then we have a number of facilitators as well. So the things that have really helped us include existing relationships, recruitment from diverse members of the care team, so nurses and obstetrics providers. We've offered incentives, so all of our interviewees have received $100 compensation for their time. And there's this potential for high impact. So that's been a draw for providers as well as patients that we've engaged to date. And then the patient facilitator component, we recruited vastly from social media, which we're a little skeptical about at first, but it ended up being the point of contact for most of our patients, and was far more effective than recruiting from the clinics has been so far. Next slide, please. So what did we find? In our thematic analysis of the providers, what we found is that there's a need for sustained focus on education for providers, especially as it relates to patient-centered care. So what we found was that providers reported implementing a uniform standard of care that focused on patients as the driver for care customization. So providers were very open to modifying care in ways that would benefit their patients. However, it is on the onus of the patient to bring forward suggestions or questions about how they would want to modify their care. And this can be a really complicated process for patients to manage, especially during pregnancy and postpartum, and even more especially for persons who are new parents. And so what we found with the patients is that they were saying, well, what's been tricky for me is that I felt like there were questions that I was expected to know to ask, but I didn't know what those questions were. So we're seeing a gap between the patients and providers on that component. And then further from providers, when they discuss the practice environments and barriers to care, what they talked about a lot was insurance and transportation, other structural factors, but they often did not discuss race and cultural values of patients, and how those may be misaligned between providers and patients. So those strategies are something that we plan to focus on increasingly during our next phase of work within the program. Next slide. So to put that into practice, we're continuing to conduct those interviews. We're conducting ongoing reviews of emergent literature. We're helping to facilitate technical assistance and training with obstetrics practices to screen, assess, treat, and refer individuals more equitably. And we're facilitating partnerships with community and state agencies that enhance the provider database that I referred to before. Last slide, please. Okay, so in conclusion, we have just begun our qualitative interviews. These interviews serve as an additional opportunity to collect rich data from providers, and they've identified important gaps and areas for growth that align with national and perinatal health initiatives, as well as our core programmatic values. So thank you so much for allowing me to share this information with you, and I'm happy to answer any questions from folks who are in the early stages of planning their own patient-facing interviews. So thank you very much.
Thank you so much, Dr. Deacon Hansen. So I got the pronunciation right, so thank you. And really appreciate your presentation, and some of the things that made me think as you were talking was if you will be using any of this data to help inform speaking with the legislature or looking at future funding for the program. So we can come back. I would now like to open it up to questions. And as a reminder that to be able to ask questions, you can you can put your questions directly in the chat box, and or you can raise your hand and we will unmute you to ask questions. So whatever you would like will be, you can do that. A couple of things that, in listening to the different presentations, I can see that that there's a lot of work that's being a combination of the qualitative and quantitative data collection, and then being able to also start to look at using some of that data towards patient outcomes. We have our first question here, and the question is, I'd like to hear more about recruitment of patients in other states. And so I will ask kind of that, I think it's a question, Ashley, that you're asking to everybody, to anybody who's on, if they are also recruiting patients in terms of for data collection activities. Is that correct?
Hi, yes, the last presenter, I like the idea with the social media recruitment, and you did a really good job laying out some of the barriers and facilitators to actually getting in contact with the patients. And I'm just curious of how the other states did it and what kind of messages or lessons learned they have around that.
Okay. Has anybody else used, thank you, has anybody else used social media or other recruitment strategies than the ones presented today? Maybe if you've done that you can include that in the chat. That would be helpful, just a response, and then that'll be documented and we can come back to questions. I see we've got another question here, or we can come back to the answers to that. We've got a question here from Carolina Clark on, are there any other PMHCA programs that are that include maternal mental health consultations? And so we know the Mdrbd programs are including that. Just want to see if any PMHCA programs are including that. And if you are, please just put that in the chat, and then you can say, yes, we're doing that. So, okay, Dr. Hoag indicated that you used Facebook. Would you talk a little bit more about using Facebook and how you use that?
Sure. We did that through Families as Allies, and we have a pretty active Facebook page with families already, and then other stakeholders. And even though a lot of those families are on there because they have children with mental health challenges or special healthcare needs, it has a broader base. So we started there. Okay. And then also did outreach through our newsletter, which has, I think goes out to about 3,000, well, maybe not that many, maybe 2,500 people, and got more that way. And then families spread the word. And we also did, and I didn't mention this in the presentation, for those families who participated, who wanted a gift card for their participation, we had a separate way, because the surveys were anonymous, that they could then separately let us know that they wanted a gift card. And I think that helped participation too.
Okay, thank you. So it sounds like really being able to have an established platform of social media, and then that was leveraged by the program to facilitate engagement. So if there's a partner organization that you're working with, or if your state or the program has that, that's a strategy for leveraging that. And so for Laura, for Vermont, you were using Facebook and being able to, and then offering the incentive around that. Anything else that you'd like to add to that verbally, or is that a good summary? Okay. Well, okay, no problem. Then we'll use that as the summary, and if there's any follow-up, that can be asked directly. We've got a question for Dr. Deacon Hansen, and that is what is the content of the community behavioral health training that you provide?
Thank you for the question, Felicity. And like I mentioned in my comment, I'm very happy to share resources with you if you'd like to send me your email. But we have ongoing behavioral health trainings that we conduct. Some of those are on specific behavioral health intervention techniques, such as IPT, interpersonal psychotherapy. We've done motivational interviewing, and we've also done trainings on moving beyond depression. And we're aiming to establish a more in-depth training specifically targeted towards health equity as well. But we've had great success with those, and they've been well received to date.
Okay, thank you. And maybe
I bet they are. That sounds fantastic. Thanks for sharing.
What I'll ask is if we're able to, if you could send them to the JBS team, and we'll make sure those are distributed or to your project officer, and they'll get it to us. Then then everyone will have access to that. Another question that I think there was another group that was using the social media component as well. Okay, then a question that I had wanted to come back to Alabama. Can you talk a little bit more about your patient outcome measures that you referred to, or how you're using patient outcome data?
Yeah, I think we're really at the point where we're trying to figure out how to triangulate some of these things. But what the team at Children's was able to do to facilitate some of this like tiered delivery of the model is they were able to, as part of their EHR, create a note, a consultation note for those patients of enrolled providers who called in and had provider to provider consultation. And then if they eventually became telehealth patients themselves, they were able to convert that. And so we've got a lot of information sort of in that intake form and on that in that EHR note, so that the goal hopefully is to be able to sort of look at things like referrals, medication usage, that kind of thing. I think that initially came about of trying to streamline and ease HRSA reporting, but it's really become really a great resource, I think, for them to be able to pull information, usage statistics, that kind of thing. And we're strategizing the best way to sort of work that into our evaluation because it's great data and we don't want to lose it.
Right. So did you, when you're enrolling or having healthcare providers participate, is that part of your training to have them use that patient note then, or?
So what will happen is that the providers will call into PASS through the consultation line, and the care coordinator who is sort of triaging that among the care team at Children's will do that intake and will access that information. And so whether it's she then follows back up with the family to sort of convert them to telehealth or not, there's that information in there to build upon.
Okay, great, thank you. And then a question for Nebraska in terms of the rural versus statewide. And if, are you shifting your program based on the results of the data that you presented at all, that to expand the rural focus where there seems to be greater need since COVID?
So in Nebraska itself, there are two main cities that are mostly rural, and then the rest, or I mean urban, and then the rest of it is mostly rural. So from the beginning, we were kind of focused on that rural component as well. And the point of the survey was to see if the statewide results themselves were masking what was going on in the rural portion as well. So we did get some of those results back to see what the differences are, and then using that to guide our clinical demonstration team in the behavioral health services that they're providing to rural providers throughout the state. So just making sure that we're actually capturing that data to kind of support what's going on.
Okay, thank you so much.
Mm-hmm.
Now, we've got 1 minute left here, and just I want to see if there are any other questions, but also say a question I have for the presenters would be about around sustainability and how much that data is either being used for legislature, or those nice quotes that were shared. Any comments on that in terms of being able to use these results in that manner? Jessica, I'll start with you.
Okay, yeah, we're definitely taking some of the results from this and then several other evaluation projects that we've kind of completed in the last couple of years of our project going on. And so we're combining those to kind of get a full picture of what's going on in the schools, in the clinics, in the family setting, and then using those recommendations for policy decisions, and then mostly just kind of getting back to our partners.
Okay, well, thank you. I know we are at time. I know would love to hear from the other presenters as well, but I want to be respectful of the time. If you've got a comment about sustainability that you want to put in the chat yet, that'll be captured to share. But thank you so much. Anything from you, Madhavi, to add to today's presentation?
No, I just wanted to say thank you on behalf of HRSA. Just wonderful presentations, and we learned so much from you today and look forward to continuing the conversation. So thanks so much.
Well, thank you, everybody, and thank you to our presenters, and have a great rest of the day. Thank you.